Hello. Okay. Uh, Assalamu alaikum, everybody. Hope you are doing fine and enjoying your holidays, long holidays rather. And today we are going to have a topic which is very rarely seen, but you can see the people around you with the gradual change in physical appearance over maybe months and years. They have worsening of their features, and they have some metabolic disturbance because of the hormone disturbance that is called acromegaly. So basically, acromegaly is a disorder of uh, growth hormone excess that can lead to excessive growth of bones and soft tissues. And that is growth hormone, which is secreted by the anterior part of the pituitary. That is, pituitary gland has two parts, anterior and posterior pituitary. Anterior pituitary is six hormones, and posterior pituitary have two hormones. And one of the important hormones from anterior pituitary is the growth hormone like FSH, LH, TSH, ACTH, and growth hormone, that is the very important hormone that is secreted by the, and prolactin is the sixth hormone. So we'll discuss the excess secretion of growth hormone from the anterior pituitary or from extra pituitary side, maybe from the hypothalamus, that is the upper area controlling the pituitary gland, and then you have some exogenous or ectopic secretion of growth hormone that may be from some adenoma, carcinoma, pancreatic carcinoma, may be associated with multiple endocrine neoplasia type 1, men type 1 may be associated features. So anyway, so growth hormone excess stimulates your bones and soft tissues, and there is excessive growth of bone and soft tissue under the influence of insulin-like growth factor. So that is the very important to make clear. So growth hormone secreted by the anterior pituitary, whether it is pituitary adenoma, most likely 99% it is pituitary adenoma, and they have an effect on the bones and soft tissue, leading to acromegaly after fusion of epiphyses. If growth hormone excess takes place before closure of epiphysis, that leads to giantism. If after fusion of epiphysis, that is called acromegaly. Means before fusion of epiphysis, if you have a pituitary adenoma growth excess, that can lead to increase in height and weight, and your body structure is like a giant. And most famous Robert Wadlow was the director in James Bond movie and Enter the Giant. That was the great man, tallest man in the world, in the history, human history, that he was almost 9 feet height and died at very young age. So acromegaly is if uh, he this growth hormone excess after fusion of epiphysis, means after maybe 25 years, then your growth is complete, and when excess hormones is there, that leads to deformation. Means that your bones which are grown up, now they become enlarged, and you have it your body features, they become deformed. So that is the, if you have a growth hormone excess before fusion of epiphysis, it leads to giantism, and after fusion of epiphysis, that lead to acromegaly. So today we will discuss the acromegaly, which is a under influence of insulin-like growth factor leading to excessive growth of soft tissues and bones. So growth hormone is the principal hormone responsible for growth during childhood and adolescence. As I told you, if you have excessive growth hormone during childhood, you can grow very tall and you can be a giant. Like many people in Pakistan, Alam Channa was the tallest man. I know who is the tallest nowadays in Pakistan, but we do remember Alam Channa was from Sindh. He was almost 10 feet height, and so growth hormone is secreted by the acidophilic somatotrophs in the anterior pituitary, and this hormone has its effects by the action of insulin-like growth factor. It is a mediator for growth promoting and anabolic effects. So growth promotion basically under influence of the insulin-like growth factor 1, which is stimulated by growth hormone. So hypothalamus is secreting growth hormone releasing hormone. That so chain would be hypothalamus secreting GHRH, acting on the anterior pituitary, leading to release of growth hormone, and uh, insulin growth factor IGF-1 from the liver. So that means through action of IGF-1, your bones and soft tissue starts growing. If you look at the epidemics, acromegaly is a very rare disease, maybe 3 or 4 cases per million, and usually it is a gradual disease. It takes few months and years that your hand, your feet, your facial features, they change. And if you look at the old photograph of people, and you can see the seeded change in their lips, in their nose, their supraorbital ridges, their tongue, their jaw, their head. Even sometimes they have shoe size changes, the ring size changes because of the enlargement of the bones and soft tissues. So that is a coarsening of the facial features. The male-female ratio almost a 2:1 also is the same. And so growth hormone basically is induces the synthesis and secretion of growth hormone by the anterior pituitary. So it is regulated by the hypothalamus. And if you have a acromegaly, that is because most of the acromegaly patients are because of pituitary adenomas. Pituitary adenoma in 99% cases, they are usually macroadenoma, more than 1 centimeter square. So pituitary adenoma, they are the most common cause of acromegaly, excessive production, secretion of growth hormones, and leading to is extrapituitary disorders. Very rarely extrapituitary disorder, like there may be hypothalamic disorder leading to excessive growth hormone releasing factor, or there may be some ectopic secretion of growth hormone from the some uh, tumors like pancreas, like liver, some other sites. Regardless of the etiology, the disease is characterized by elevated growth hormone, and it is the growth hormone which leads to increased secretion of insulin-like growth factor, which results in the symptoms and signs of acromegaly hyperstomatopism. So if we go to the etiology, the causes, that means if you have a excess growth hormone, that is a pituitary adenoma. Pituitary acromegaly is the most common, almost 95 to 99% cases. The pituitary acromegaly is because of the excessive production of growth hormone from the pituitary adenoma. And these are the adenoma which are basically produce excessive amount of pituitary hormones, leading to excessive production of insulin-like growth factor and affecting the bones and soft tissue to grow, and the patient have a deformed character. There is a coarsening of features, and you can have a metabolic also effects, and there are changes in the skin, bones, internal organs like viscera. You can have cardiovascular effect, metabolic effect. You can have other effects which we'll discuss later on. So it may be from the first, most likely it's from the pituitary adenoma, pituitary hyperplasia, or from the hypothalamic hypersecretion like growth hormone releasing hormone. Extra pituitary sites may be because of some adenoma, may be part of endocrine neoplasia, multiple MEN1, or some other sites. And growth hormone releasing hormone may be from the other sites. So ectopic pituitary adenoma, usually they are very rare pituitary carcinoma, may spread to the meninges and CSF, cervical lymph nodes, and other metastatic deposits. Okay, now acromegaly due to excess hormone and acromegalyism is a other term which is used when you have a soft tissue and skin changes which are usually similar to acromegaly, but they are normal baseline dynamic growth hormone and IGF-1 are normal. So it is the basically some abnormalism which takes place, and it is not under the influence of the growth hormone. That will be discussed. So this is acute Albright syndrome is the hypersecretory syndrome that is consists of polypostosis, fibrosis, cutaneous pigmentation, sexual precocity, hyperthyroidism, hypercorticism, and hyperprolactinemia. That is a part of acromegaly, that is called acute Albright syndrome. So few patients have definitely evidence of pituitary adenomas, and they can have mutations at some site, but this is a syndrome consisting of acromegaly, where hypercorticism, hyperprolactinemia, pigmentation, etc. This is a separate syndrome in association with acromegaly. Okay, I told you the causes most likely is pituitary adenoma in 95 to 99% cases, or pituitary hyperplasia under influence of hypothalamic growth hormone releasing hormone. Ectopic growth hormone secretion from tumor anywhere, or there may be a part of multiple endocrine neoplasia, that is MEN1. Growth hormone pituitary adenoma is a well documented component of MEN1, that is autosomal dominant inheritance, and it consists of parathyroid, pancreas, and pituitary adenoma with associated MEN1. If we look at the hypothalamic pituitary axis, that is, you can see that normally primary growth hormone usually is under influence of growth hormone releasing hormone. It acts on the anterior pituitary, cause release of growth hormone, and then growth hormone, if there is a normal, you can have a normal cardiometabolic or somatic effects. But if you have excessive growth hormone, either from pituitary or from the hypothalamus, you can have excess growth hormone leading to insulin-like growth factor 1, that is the IGF-1 under influence of growth hormone lead to somatic growth and metabolic dysfunction. So normally it is the hypothalamic pituitary and IGF-F secretion, IGF-1, that leads to growth of somatic and metabolic dysfunction. So causes, as I told you, it may be pituitary, extra pituitary side, or pituitary hyperplasia under the influence of hypothalamus, or from ectopic secretion from some adenomas or carcinomas anywhere, maybe carcinoma of the lung, carcinoma of the prostate, carcinoma of the kidney, liver, and they can be ectopic side of growth hormone secretion, and maybe a combination of like Albright syndrome or MEN1 with the association of parathyroid, pancreas, and pituitary tumor. Okay, now we go to the what is the effects, what are the clinical features if someone is having excessive amount of growth hormone leading to excessive IGF. That means your tissues and bones are stimulated because of highly circulating growth hormone, which have a effect on the liver to cause the release of IGF-1. So if growth hormone is in excess in childhood, that means that child is going to have a excessive growth of bones and soft tissue leading to giantism. He will be taller as to his age. And pituitary giantism is very rare. In a total like I told you, there are few examples like Pakistan, we have Alam Channa and other important characters. They have giantism. If growth hormone excess occur in adults, after fusion of epiphyses, if epiphyses are closed and you have effect of growth hormone, that leads to excessive enlargement of the body parts. That means it may be your acral parts or tips of the body, means you can have the large big nose, lips, hands, feet, macroglossia, your supraorbital ridges, and the skin effect, and you have a other visceral enlargement like heart and other we'll discuss later on. So in addition to soft tissue, internal parts of the body enlargement acceptable. So it is the brain which is not affected by growth hormone, but other tissues are affected, leading to enlargement and disfigurement. You can see the example that was the gentleman who had his photograph. That was after a few years. You look at the hand, it's a spade-shaped hands, and if you handshake with these people, they have a Duffy and diaphragm. You can feel their hand like spade-shaped hands. Look at the lips; they are enlarged. Nose is a bit wider. Supraorbital ridges are more prominent. Jaw enlargement takes place due to prognathism, and there is a widening of the teeth spaces. So these are all clinical features which takes place over years and months. So that is very important. If you want to see someone who is acromegaly, look at their old pictures and you can see the changes all over the face that takes place, hands and feet, and ring size is enlarged, the shoe size is enlarged, and then even hat is size is enlarged. And this is another picture just to see the spaceship hands and the lady with the wider nose, jaw is enlarged, supraorbital ridge is more prominent. So, and in children they may have frontal bossing. And another picture just to see the macroglossia, the tongue is enlarged, you can have the nose and prognathism, and again spade-shaped hands, large nose, and there is a jaw is leading to prognathism and widening of the teeth spaces. This is you see the patient with giantism before closure of apical. These are not apical, these are giant. And this is the acromegaly. When you see the people who have a change in the feature, this is the acromegalic phase, and this is the giant phase. Okay, this is another picture. You can see the how the gradual changes takes place. If we look at the picture of 1977, and after about uh, 4 years, you can see the gross changes. That means you can have the big nose, you can have lips changes, you can have tongue changes, and your skin becomes rough and thick because of the influence of growth hormone. Another lady with the acromegalic features, look at the nose, look at the lips, and all the supraorbital ridges and jaw, prognathism, and teeth spacing, and the dry and curly hair. You can see the how the excessive growth of tissues takes place under the influence of growth hormone and IGF-1. Clinical manifestation, we'll see whether most common it is because of the pituitary adenoma. So you will have the local effect on the pituitary site, leading to patient may have headache, compression. You know the visual field defects can have bitemporal hemianopia. Patient can have hypoprolactinemia because of the pituitary adenoma, leading to compromised of other pituitary hormones, and patient may have hypopituitarism, may have hypothyroidism, loss of TSH, loss of FSH, LH, leading to hypogonadism, hypercorticolism, ACTH deficiency. So pressure effect, mass effect of the pituitary adenoma can lead to compression of the pituitary gland itself, leading to hypopituitarism. And systemic effect of growth hormone IGF can lead to visceromegaly, soft tissue and skin changes, and thickening of the acral parts, increased skin thickness, soft tissue hypertrophy, and hyperhidrosis, oily texture, skin tags, and acanthosis nigricans. Acanthosis nigricans is a velvety skin appearance over the back of the neck. It is also part of the metabolic syndrome when you have glucose insulin resistance. That is the early feature of diabetes insipidus. Diabetes mellitus. Cardiovascular effects, patient can have hypertrophy, ventricular hypertrophy leading to congestive heart failure, and patient can have hypertension, cardiomyopathy, arrhythmia, and risk of coronary artery disease. Coronary artery disease is increased because of there is a high risk of getting hypertension and diabetes mellitus because of insulin resistance. And the respiratory manifestation of acromegaly can be macroglossia, jaw malocclusion due to enlargement of the jaw due to prognathism and malocclusion. Upper airway obstruction leading to sleep disturbance like sleep apnea, and central and obstructive sleep apnea maybe there may be ventilatory dysfunction leading to hypoxemia, and patient may have snoring and early morning headaches. Metabolic effect, as I told you, the growth hormones lead to it is an anti-insulin effect. It will lead to impaired glucose tolerance, diabetes mellitus, and insulin resistance. And other endocrine consequences may have goiter, hypercalciuria, hypercalciuria leading to calcium stones and nephrocalcinosis and renal failure. Galactoria, it is libido and impotence in males and menstrual irregularity and reduced fertility in female because of the acromegaly effect on fertility problem. And it may be part of your pituitary compression leading to hypopituitarism, leading to loss of FSH, LH, or it may be as a part of metabolic disorder leading to pituitary and peripheral effects. So bone changes may lead to increased articular cartilage thickness, especially if you look at the heel pad. I'll show you the photograph of how the thickened heel pad takes place under influence of growth hormone. So arthralgias and arthritis, especially sacroiliitis, and most important, carpal tunnel syndrome. The median nerve compression bilaterally is a feature of growth hormone excess in acromegaly leading to carpal tunnel syndrome. And osteopenia, bone may become fragile leading to osteoporosis and may have fractures. So this is the jaw prognathism and mandibular overbite. That is, your jaw is overgrown and there is a malocclusion. Your bite is overbitten and wider in size of teeth. You can see the spacing of the teeth is increased. And this is the colonic manifestation. Colonic manifestation, you can have large megacolon or you can have polyposis and diverticular disease. There are different colonic manifestation seen in acromegaly. The clinical manifestation of acromegaly, including the skin, are hyperhidrosis, oily skin, and maybe unpleasant odor, and because of the glycosaminoglycans deposition. Pigmented skin tags can be a part of acromegaly, and they are usually because of the excessive growth hormone under the influence of IGF-1. And insulin resistance, I told you, can be part of leading to ischemic heart disease and because of dyslipidemia. So rare manifestation is cutis vertis gyrate. That is your scalp wrinkles. Your scalp skin becomes rough, and patient can have even psoriasis. And there is a osteoarthritis. Sometimes vertebral enlargement can lead to your spinal stenosis. Cord compression can take place because of the excessive growth of vertebral bodies. And carpal tunnel syndrome, I told you, can be a part of acromegaly in 30-50% of patients, and it is usually bilateral. And predominant pathology is a median neuropathy. Median nerve is compressed because of the increased edema of the median nerve in the carpal tunnel syndrome. Bone tensometry can see the osteopenia, and there is excessive growth hormone leading to hypogonadism and growth hormone, the influence of growth hormone. Cardiovascular manifestation really seen in 60% of patients. And elevated growth hormone can lead to hypertension, heart disease, leading to left ventricular hypertrophy, leading to congestive heart failure, sometimes leading to arrhythmias like APCs, BPCs, ventricular tachycardia, or they can have other manifestations as part of cardiomyopathy. So arrhythmia like fibrillation, supraventricular tachycardia, ventricular arrhythmia can be seen in especially during exercise. And other cardiovascular effects in acromegaly, including hypertension. So increased rate of hypertension and diabetes is seen with high triglycerides in patient with acromegaly, and that is going to be a effect leading to coronary artery disease, because hypertension, diabetes, high dyslipidemia is risk factor of having coronary artery disease. So hypertension is considered one of the most important prognostic factor mortality, because if you patient with acromegaly, he is hypertensive, having cardiac manifestation, and top of impaired glucose tolerance, diabetes, he can have cardiac manifestations. And growth hormone excess can lead to insulin resistance. That means your ability to insulin to stress glucose production stimulates is impaired. So frank diabetes mellitus insulin resistant and frank diabetes mellitus is found in 15 to 56% of patients. They can have diabetes. So carbohydrate intolerance in 30 different studies have shown to be very high in patients with acromegaly. So acromegaly has a respiratory problem, can maybe because of patient may have sleep apnea or may have impaired respiratory function. So sleep apnea is a phenomenon when you have a apneic spells during sleep and patient become hypoxic, he snores out, and you can make a diagnosis by polysomnography. That is a sleep study and to document the apneic spells and hypoxemia and the patient waking and having apneic spells. The patient with acromegaly can have barrel-shaped chest or vertebral and costal morphology. Even vertebral enlargement can lead to spinal cord compression like spinal stenosis. So upper airway obstruction may be part of macroglossia, prognathism, thick lips, hypertrophy of the laryngeal mucosa and artery. The laryngeal and pharyngeal mucosa can lead to thick voices. Your can lead to deep voice. And in these patients, if they are required to be intubated, intubation will be very difficult to intubate during anesthesia in these patients with acromegaly. So other features like obstructive sleep apnea and patient with sleeping disorders are very common in patient with acromegaly. Okay, other hormone disorder like hypercholesterolemia with the galacturia may be part of pituitary disorder and in association with acromegaly. And thyroid and enlarges uh, enlargement may be seen in acromegaly as a goiter. Hypercalcemia, I told you there are some electrolyte and mineral problem. Patient may have a hypercalcemia, hyperphosphatemia, hypercalciuria can lead to nephrolithiasis, and that can be seen in 6 to 77% of patients with acromegaly. That is excessive bone marrow, excessive hypercalcemia leading to hypercalciuria, leading to renal tubular acidosis and calcium deposits. Gastrointestinal manifestation, I told you in colon, there are maybe polyps and there may be large megacolon. Colonic diverticular disease are also found very common in patients with acromegaly and diverticulosis. So you can have colonic large colon with polyps with diverticular disease, and patient can have a colonic effect. Even increased risk of CA colon can be seen in patient with acromegaly. If you see the patient with the acromegaly colonoscopy, just to rule out the evidence of colonic carcinoma, or if they have a risk of if they have a polyps that can lead to malignant transformation leading to colonic carcinoma. Skin manifestation, they can have multiple skin tags and this pigmentation of the skin, and there may be it is because of the IGF-1 which leads to patient with the skin tags and pigmentation. Okay, patient with acromegaly can have different cancers of different organs of the body like prostate, breast, colorectal, lung, thyroid, and other carcinomas because of the IGF is increased. So these are the physiological and metabolic effects of patient with acromegaly. So cancers most commonly acromegaly may be because of the colon, breast, prostate, and there may be a hematological manifestation, may have bronchial, gastric, esophageal, thyroid, goiter, simple goiter, thyroid carcinoma, and osteosarcoma, pancreas may be associated with MEN1, melanoma, ovarian, renal, and adrenal and biliary tract diseases. So these are the all clinical manifestations which can take place in patient with acromegaly. If we look at the different studies which have been done, this was the Indian study, and they have found the male to female ratio was 2:1, mean age was 35, because your epiphysis close. Before that, you get giantism, and acromegaly once you have a closure epiphysis and you are you develop the feature of acromegaly. Duration symptoms usually over months and years. Patient may present a headache, visual impairment because of the visual field defects, especially the bitemporal hemianopia can be seen in 23% of patients. If you do their visual perimetry, and you will see the visual field defects. Pituitary apoplexy, if the pituitary adenoma can lead to internal hemorrhage and necrosis, then can lead to pituitary apoplexy, sudden severe loss of pituitary hormones, leading to patient can go into shock state, and that is one of the complications of adenoma, leading to acute hypopituitarism, that is called pituitary apoplexy, because of the internal hemorrhage and necrosis. Hypothyroidism, that I told you, can be a part of your pituitary adenoma itself, leading to compression of the anterior pituitary with the decreased release of hormones like TSH, ACTH, your FSH, LH, and these hormones are suppressed, leading to hypothyroidism, hypocortisolism, even sometimes there may be high increased secretion of prolactin, leading to hyperprolactinemia and galacturia. And avoid diabetes is found in 28% of patients because they have glucose intolerance and insulin resistance. These are the few photographs. Just look at the foot X-ray of patient with acromegaly. If you look at the heel pad, this is called thickening of the heel pad. You look at the heel pad, the soft tissue of the heel is almost enlarged, and this heel pad is a classical picture of patient with acromegaly, thickening of the heel pad. And this is the picture or X skull of the patient with acromegaly. You can see there is a frontal bossing, large jaw, and dental malocclusion, and that is a progantism, and jaw is enlarged, leading to progantism and malocclusion. If you look at the jaw, the bite may be, that is called this is a malocclusion, and there is a jaw is enlarged. You can have the frontal sinuses are also enlarged. Okay, so patient with suspected evidence of clinical and symptomatology of acromegaly, you can see patient may complain of enlarged hand size, ring size, hat size, or may have a shoe size enlarged over. This number was like 7, now it gone to 9 and 10. So you suspect that, look at the face of the patient and suspect the disease, then you make a diagnosis on clinical and your lab investigation. So suspicion of the disease is very important. Patient will have changes on their face. They can have lips changes, thick skin, large nose, supraorbital ridges, protentism, and spacing of the teeth, malocclusion, and patient can have dry, thick skin, and curling of the hair. And these are all facial features, macroglossia even. And if you look at the hand, they are spade-shaped hands. They can have large feet, and shoe size may increase. And if you go for systemic review, you can have cardiomegaly, you can have hypertension, metabolic profile, patient can have diabetes. So this is all clinical manifestation of growth hormone influence leading to acromegaly. So diagnosis you have to document by clinical and biochemical test. So acromegaly is an insidious disease which is often diagnosed between 4 to 10 years. The patient can have gradual change in their physical appearance. Early diagnosis of for that you have to document the oversecretion of growth hormone and IGF-1. So these are the hallmark of the acromegaly: excessive secretion, oversecretion of growth hormone either from the pituitary, extra pituitary side, or leading to excessive secretion of IGF from the liver. Patients with the renal impairment and hepatic disease, they can have impaired secretion of IGF-1. But the diagnosis is mandatory when you have a excessive secretion of growth hormone IGF-1 and leading to metabolic and somatic effects. So another possible method for early diagnosis, a patient with acromegaly, they can have, you can see their photographs. So comparison of photograph maybe 5 years back and a recent photograph will tell you the positioning of the features of the face, including the lips, your nose, your supraocular ridges, and prognathism. So this could be a feature of making a suspicion and diagnosis to compare the old photographs. And you can see how the gradual facial feature changes in patients with acromegaly. You can see the nose size, the lip size, supraorbital, your brows, and this is the gradual changes over maybe 15 to 20 years that changes from the fine hair and features leading to coarsening and dullness of the features. So normal growth hormone production is usually pulsatile. Growth hormone production is increased during stress, sleep, during puberty and pregnancy. So these are the four factors which are normally your growth hormone increases. Again, repeat, when you are sleeping, you are under stress, and in pregnancy and puberty, your growth hormone level increase. Old myths is if you sleep, you increase, you are taller. Good sleep makes you tall. That is the reason why this growth hormone production is increased. It is a scientific reason for that. You have a pulsatile secretion of growth hormone. Random sampling is not very diagnostic. You can check the growth hormone level that falls 0.1 to 0.2 microgram per liter in normal subjects. But maximum production occurs at night when you are sleeping. So growth hormone can be checked over average over 24 hours, but the important diagnostic hallmark is the IGF-1, which is a biomarker of activity of acromegaly. So growth hormone leads to secretion of IGF-1 from the liver, and that is the most stable, relatively stable, and it correlates with the clinical evidence of acromegaly and elevated growth hormone levels. So IGF-1 is the most accurately assessed IGF levels according to age and the patient. And if we see the levels of growth hormone IGF-1 levels are increased, that means you can have a very strong evidence of patient with acromegaly. Then you can visualize the pituitary foci itself, leading to pituitary gland by MRI with the contrast and enhancement. Contrast is given just to see the vascularity and the surrounding structures. So there may be microadenoma or macroadenoma. Usually pituitary adenomas are macroadenoma more than 1 centimeter square, and they may extend into cavernous sinus or suprasellar region. So MRI is a very good radiological diagnostic technique to see the pituitary tumor itself and the plan for surgery with evidence of excessive production of growth hormone. If pituitary foci is okay, growth hormone and IGF-1 are increased, that may be from the extra pituitary side, meaning the ectopisation of pituitary, that is the other sides of secretion. Diagnosis of acromegaly requires measurement of growth hormone during cook. Then we check if growth hormones increase and IGF is increase. Then you check a test that is called glucose growth hormone leading to glucose tolerance test. That is 100 gram of glucose in syrup is given and you check the growth hormone response. Normally the growth hormones is stressed by taking glucose, and in acromegaly there is a failure of suppression. If your growth hormone and IGF-1 is increased, you have seen this patient is most likely case of acromegaly. To go for glucose tolerance test, and it is glucose, usually 8 hours fasting is required, and patient is checked for glucose and growth hormone IGF-1. Usually half hourly it is checked, like 0, 30, 60, 90, 120 and 150 minutes apart. It is checked. Six levels are checked and it is seen the response. If there is suppression of growth hormone after glucose, that is a normal phenomenon. In acromegaly, there is the failure of suppression. The growth hormone IGF will not be suppressed by glucose. So that is a feature of acromegaly. In healthy subject, the growth hormone initially falls, but in patient with acromegaly, there is a fail to suppress the growth hormone and IGF-1. So serum IGF-1 levels are high and correlate to the serum GH determination. So this is we can see the biochemical change in pituitary response after glucose tolerance test, and it is a very good suppression test seen in normally and in patient with acromegaly. So failure of suppression of growth hormone in acromegaly. Differential diagnosis may be you can have a patient with other features of growth hormone, and MRI scanning can be done. But what are the objective for treatment? So objective of treatment is to, number one is, if pituitary adenoma, you have a features of compression of the pituitary gland itself, and the objective is to reduce the size of the tumor mass itself. So tumor mass should be reduced, and symptomatology of the patient due to oversecretion of IGF-1 should be controlled, like hypertension, your cardiac effects, your glucose intolerance, and all these metabolic effects are, and your skin changes. They take usually time, but then cardiometabolic effects are very, very important to be controlled after treatment. So aims are comprehensive strategy of treatment to acromegaly should be managed. Number one, pituitary mass itself, because it may have compression leading to loss of other hormones, that is called compression of the may have TSH, ACTH, FSH, LH. They may be lost leading to hypothyroidism, hypocortisolism, and disorders with fertility and menstruation. So pituitary mass itself and the pressure effects. And elevated growth hormone can be treated by medication and other subjective treatments. The serum growth hormone level should be suppressed at least 1 microgram after glucose. That way, we told you, in good control, they are usually very well managed. So you can have options are, basically objective is, number one, to suppress the growth hormone production from the pituitary. Number two, to reduce the mass effects of the pituitary tumor itself. And we have options like you can have medical management, radiotherapy, and surgical management. The surgical management usually is done when it is a well circumscribed hematotroph cell adenoma, and that is roughly dissected by transsphenoidal hypophysectomy. So transsphenoidal surgery is done if you have a well circumscribed pituitary adenoma, because usually they are benign tumors. Usually more than 90-95% they are benign, but sometimes local spread to cavernous sinus and other surrounding structure can take place, and very rarely they are malignant. So successful resection alleviates the preoperative compression effects and compromise the trophic hormone secretion and preservation of the anterior pituitary function. So it is the surgical removal of the pituitary adenoma, pituitary mass or tumor, which leads to reversal and preservation of the normal pituitary function. Otherwise, if you have an enlarging pituitary tumor, that can lead to compression and leading to loss of other pituitary hormones and leading to hypopituitarism. So within 2 hours after successful resection, metabolic dysfunction and soft tissue swelling starts improving, and growth hormone levels are sometimes controlled within 1 hour. So it is a very good technique, transsphenoidal surgery, which can have is very good result. But there are few complications. Like this is the picture of how you go. And enter the pituitary fossa, and this is the nasal cavity, and you go for pituitary tumor, and this is a transsphenoidal to the cephus bone. You go to the transsphenoidal surgery is usually the first line of treatment and may result in cure of growth hormone excess. Treatment is successful depending on the size of the tumor. Usually 1 centimeter is a macroadenoma and it has a high cure rate. Larger size tumors lower the cure rate. If you have a already large tumor which is expanded and has compressed the pituitary itself, leading to loss of pituitary hormone, it has a bad prognosis. But tumor size around 1 centimeter has a better prognosis. What are the surgical outcomes correlates with the adenoma size, and smaller tumors are usually do better than the larger tumor. Side effects of transphemoral surgery, they can lead to a transient and surgical complications, and patient can have a hypopituitarism. Sometimes the healthy part of pituitary gland is also removed, and other complications are loss of pituitary ADH leading to hyper insipidus. Sometimes CSF rhinorrhea, CSF leakage can take place through the nose, and that is a risk for meningitis and infections. Hemorrhage and meningism. Meningitis can take place in patients with CSF rhinorrhea. Is one of the complications of transsphenoidal surgery. And radiation, yes, radiation techniques are other very important. And when radiation therapy for acromegaly is being considered, it should be conducted experienced pituitary radiotherapists and specialized center. Radiation is done by to debulking the tumor and by in adjuvant with the medical therapy. So primary adjuvant in radiation of growth hormone secretion tumor may be achieved by conventional external deep X-ray therapy or heavy particle proton beam or gamma knife radio surgery. So these are the radiation techniques which are used to remove the large tumors, and precise MRI localization, stimulation, and isocentral rational techniques are with high voltage, especially they have improved the efficacy of radiotherapy. 5,000 rads are usually given to for the radiotherapy, and radiation arrests the tumor growth, and most pituitary adenoma usually they are treated. Next technique is stereotactic pituitary tumor ablation by the gamma knife. This is a new technique which have been used in patient with the pituitary tumors, in patient with acromegaly. These are the new techniques where gamma knife is used, and 82% goes to they had a normal serum IGF levels. This is very high cure rate. There is a one center in Karachi where gamma knife is there. It is a good technique for removing the tumor, especially dedicated surgery like brain and other surgeries are done, and it has a very good result. Some of these patients were being treated simultaneously with the spectral analog. This is the adjuvant therapy with radiation and with gamma knife and medical treatment. 50% of the patient achieved glucose suppression, that is, the glucose intolerance was improved. Side effects usually can lead to radiotherapy, the pituitary trophic hormone disturbance. Sometimes there is a hair loss, cranial nerve palsy, tumor necrosis with hemorrhage, that is the pituitary plexus can take place, and in few patients. And patient can have lethargy, impaired memory, personality change. That is because of the local effect of radiation. Medical management very important. If patients are usually given medical therapy first unless they have a pituitary adenoma, enlarging tumors of the pituitary gland that lead to be removed surgically and by radiotherapy. But at the adjuvant therapy as a medical treatment is also given. Usually it is good for patients who have a small tumors and do not have compression or pressure effect of the pituitary fossa itself. So dopamine agonists are used like bromocriptine, and other drugs are used, and serotonin receptor like factor receptor ligands and the growth hormone receptor antagonists. These are the new drugs which are growth hormone receptor antagonists, and serotonin receptor ligand growth hormone. They can be used in combination. Dopamine agonist like bromocriptine is a good drug, and uh, cabergoline. Cabergoline is a new drug which is given twice a week. It is a bromocriptine is given 0.25 to 2 milligram per day, but cabergoline has been used as adjuvant therapy because it is easy to use. It is given twice a week, which is a good drug. Usually up to 20 milligram bromocriptine lowers the growth hormone levels, and approximately 15% of patients worldwide have been reported to successful growth hormone secretion by dopamine agonists, that is either bromocriptine or cabergoline. Dopamine antagonist ethically appears to be independent of dopaminergic respiration. They have a few side effects like gastrointestinal, transient nausea, vomiting, headache, transient also hypertension, dizziness, nail stuffiness, and peripheral vasospasm. And cabergoline may be useful, and especially patients who prefer oral medications, and sometimes patients who have after surgery they still have the features of high IGF, and you can have combination of after surgery you can put them on cabergoline. That is a good drug to. Then you have a somatostatin receptor analogs that can be used. The somatostatin receptor intrinsic factor receptor ligands are used like as a first line therapy when there is a low probability of surgical cure. If patient large extracellular tumors, there's no evidence of central progression, and patient have a dissectionary recommendation that these are the patients who are given these drugs. So before surgery, it is very important to see what therapy would be used for that patient. If patient have a compression effect, patient have some surgical pituitary compression leading to hypopituitarism, tumor size is large, and you can go for adjuvant therapy and with combination of surgery and even gamma knife treatment. Okay. Somatostatin analogs available clinical use are cyclic octreotide and octreotide. Octreotide and lenactreotide. These are the drugs which are used. Octreotide is 45 more 5 times more potent in suppressing the growth hormone, which the onset growth hormone secretion. Somatostatin analogs are biologically effective by activating the somatostatin receptor. So these are the drugs which can be used in patients who can be fit for surgery and adjuvant therapy. Improvement in signs and symptoms of acromegaly overall 64-74% with report along therapy. So these are the drugs which are simple to use and very effective. And if patient cannot afford surgery, or if they have a contraindication for surgery. A number of studies have shown improvement in somatostatin analog and cardiac structure itself. So they are indicating the cardiac safety profile. Another important component of the efficacy measured analog for acromegaly is effect on the tumor shrinkage. So overall, in combined data from patients receiving either long-acting analog or octreotide adjuvant therapy, 30% patients have a tumor shrinkage. So acromegaly is in addition to biochemical control, reduction in tumor volume, long-term treatment is associated with improvement in symptoms of acromegaly, headache, fatigue, perspiration, and osteoarthritis. Okay, third variety, the growth hormone receptor antagonist. Growth hormone receptor antagonists are the drugs which are persistently used for patients with elevated IGF, despite the maximum therapy in somatostatin analogs are used. So possibly monotherapy of or in combination with the somatostatin receptor analog and patient with these are the drugs which are highly effective, especially ecdystroment is highly effective in acromegaly and significantly improves the quality of the life in patient that require the somatostatin receptor analog and ecdystroment to achieve the biochemical control. So basically, in treatment we have three options: either medical treatment, surgery, or radiation therapy. Patient objective was to reduce the mortality of the patient and tumor shrinkage and treatment of comorbidities. Comorbidities means patient becomes hypertensive, glucose intolerant, and may become diabetic, and you have to treat the associated problem as well. So monitoring the patient acromegaly biochemical markers of response like growth hormone and IGF-1, they are the markers to see whether they have come to normal or they are suppressed. And looking for the radiological evidence of pituitary mass, pituitary fossa itself by MRI, pituitary function, echocardiography to see the cardiac manifestation, whether they have left ventricular hypertrophy or heart failure. Sleep disturbance can be monitored, and patient may have better sleep studies, and colonoscopy to see if they have any evidence of neoplastic change, especially patients who have colonic polyps and patient with the diverticular disease. So significant progress has been made in management acromegaly in recent years by multi modality team with specific experience in mandibular pituitary tumors. But still, there are few patients who still have they are still undiagnosed, and those patients you need to check their growth hormone and IGF levels and see the pituitary fossa itself on MRI. And for that matter, first of all is the physical appearance of the patient. So it is very, very important to see the physical appearance of the patient to see what are the changes which takes place in patient with acromegaly, especially patient who have a classical changes of facial appearance. They have big nose, lip changes, jaw changes, or orbital changes, or have spear-shaped hand, your ring size increases, your head size increases, your shoe size increases. If you compare the old photograph of the people, you can see the drastic changes that takes place in their physical appearance, and you suspect the disease. Check their hormone levels, especially I told you they are in pulses. But glucose tolerance test is a very, very important to check their growth hormone IGF levels. If they are suppressed normally, but in patient with acromegaly, they are high and not suppressed by glucose tolerance test. And after documenting that biochemical evidence of growth hormone IGF-1 excess, you can go for pituitary fossa by MRI and treatment options. You have transsphenoidal surgery, medical therapy, and radiation by even by gamma capra, the gamma knife. So these are the features of patient with acromegaly, and I hope you have some. You must have seen maybe in your life few patients, but most of the patients who have a gradual worsening and disfigurement and changes in old photograph, you compare them. You can have the patient may present simple hypertension, patient may present new onset of diabetes, patient may present with a heart failure, and these features are suggestive of acromegaly. Then you start thinking probably this patient is acromegalic and he is now presented with cardiometabolic complications. So early diagnosis and early treatment can save the complication and life of the patient. So I thank you very much for your listening and say you goodbye, assalamu alaikum, and wish you all the best. Okay, Allah Hafiz.